Okay, so personality assessment is what you would use for a new client. It's what you would use in like a legal situation to figure out, is this person, not guilty by reason of insanity? It's also very frequently used in research as well. So this is really a lot of the core of what clinical psychologists do. So it's really good to do this in multiple ways, have multiple instruments, and you can get a sort of like when you're writing a paper, right? You try to get all these different sources and integrate them. And that's sort of what you can do with assessment. And this PowerPoint is posted on Blackboard, so don't feel the need to like scribble everything down, or feel free to download it and follow along that way. So just like with therapy, we want to use assessments that are evidence-based, that have a body of research behind them that says this works, this has the research behind it, that we're confident enough we can use it to make big decisions about people's lives. So I'm not going to get into the nitty-gritty of it, but basically you want it to have good, what we call psychometrics. Fancy word that means it works, basically. So you want it to work, and one of the things we look at is reliability. And this goes, it's on a like 0 to 1 scale, where closer to 1, the better it is. And typically when we do questionnaires for like research, 0.8 range is good. If we're using them to make like diagnostic decisions, we want things that are in the like 0.9 or above range. So like the WAIS and the WISC that Dr. Jensen went over the other day, those are in that range. And so you want to make sure there's good normative data, and that the normative data are diverse. So historically, this has not been the case. For example, the MMPI, which we'll talk about, it was normed on just people from Minnesota in the 1930s. They were very white. They were very of Scandinavian descent. A lot of them were farmers. Not surprisingly, that did not translate well when you tried to use those norms that were created for that population with the rest of the US population. And a lot of times, there are things that are just looking at one thing, but some of these are more comprehensive, and we'll talk about that. We also want to make sure that we are being as culturally competent as possible. So the clinician themselves should have training in, hey, this kid, doesn't speak English. What do I do? Instead of just like trucking along, right? Then you refer to someone who speaks their language and can test them in their language, or things along those lines. We also want to make sure that tests, as I was just saying, can be used with culturally diverse and ethnically diverse samples. And then also we have to think about, how we're interacting with people. A lot of, maybe not surprisingly, a lot of the momentum in really since I was in grad school in the aughts is to put things digitally, right? Put them online and you react to them that way. Well, one of the problems with that is, what if you have an elderly person come in who's not very technology savvy, right? Then you could be getting inaccurate responses just because they're struggling with the tech, right? So what I am mostly trained in are objective personality tests. These have unambiguous items, limited range of responses. Sometimes it's literally just true, false. They're objectively scored. For some of them, there's actually computer scoring. You just kind of run a Scantron through. Typically pencil and paper, or, again, the digital version of that. And they're direct, brief statements or questions. All right, so this is one of the reasons why I'm going to kind of use the PowerPoint only as guidelines. So the MMPI is actually on the MMPI 3 now, but the PowerPoint for your book, which is what I use as the template for this, only had up to the 2. So the MMPI-2 was revised in 1989 and had much better samples. They very consciously went out and got a representative sample of the US population at that time. They also removed items that were inappropriate or illegal to ask, because the MMPI is often used for screening for people who want to be police officers or firefighters, and there's certain things you can't ask for that, right? Then in 2009, I believe, 2008, they came out with the MMPI-2RF, which is the restructured form. And it kind of took the MMPI, took a step back and said, let's clean it up. What they found, and this was actually largely, and I could flip forward, I have a slide with him. Largely the work of my grad instructor, Yossi Ben Porath. So he and his lab had been working for years on trying to figure out what are these scales that exist actually measuring. And we'll go back and kind of talk through the scales. But essentially what they found is that because of the way the MMPI was originally created, there were a lot of scale items that were used on multiple different scales. So the same item might appear on the scale for depression and the scale for anxiety and the scale for schizophrenia. And when they looked at those items, they just measured essentially general distress. And that makes sense, right? If you are having a psychological issue, by definition with the DSM criteria we've looked at, right, you're gonna have distress or impairment, right? So they pulled that out and they made their own scale with that. That was called demoralization. And then they cleaned up everything else. And then just last year, I don't know, what is time? Maybe the year before. But they came out with the MMPI-3, which I took a 7-hour online workshop with Yossi. It was great to take class with him again, to learn so that I could teach y'all about it. So I'll kind of hop back a little bit here now. And so it's much shorter now. And there are a variety of different types of scales that measure things. There are validity scales, which at the time were really novel. So these, you heard Dr. Jensen mention these in passing the other day. These are scales built into the test that look at things like whether they're paying attention. There's a scale that just measures, are they trying to just go through and put all true or all false? There are scales for things like faking good. So let's say you are doing the MMPI as part of a child custody eval. You might want to make yourself look super awesome. So you're the one who gets custody, right? And in fact, we know that so much that there are different norms we use for child custody evals for this scale. There's also a faking bad scale that looks at, people who are in real distress sometimes might just sort of exaggerate their symptoms as a cry for help. And then the extreme of that could be, let's say you are trying to say, oh, I'm not guilty by reason of insanity. You might endorse items that even someone with very severe psychopathology would never endorse, right? And then these were the original scales of the MMPI, the clinical scales. These are kind of moot now. But just to show you how these used to be and how they really are still presented to the clinician after you run it through the software. We have graphs like this, and you can kind of look at what the various interpretations are. Again, trying to skim. So I mentioned there were some issues with the way it was originally constructed. So it was constructed using a method called empirical keying. And what this meant is you had people who had the disorder. So you're like, I want to figure out a scale that measures depression. And they had a whole bunch of people who were getting treated for depression answer these questions. Is it true of you? Is it false of you? And then they used a comparison group of people who supposedly didn't have depression. I'll say in a minute why that might have been problematic. but, you know, had them answer it. And basically the items that went on the depression scale were the ones that the people who were being treated for depression said, yep, these apply to me. And the ones who were not in treatment for depression said no. So a couple issues with that. One is that their control group they used for the original MMPI was families of the people who were getting the treatment. What could possibly be the problem there? What do we know about psychological disorders and families? Yeah.
It's like genetic.
Yeah, exactly.
Schizophrenic, the dad is more likely to have to live with it also depends on their environment.
Exactly. Yeah. So like we know there are genetic things linked. So it's possible that these people like had the propensity to it, or maybe it was like an inpatient treatment facility where they were doing this. Maybe these people like had depression, but just not bad enough to get inpatient hospitalized. So that's why they sort of really had to go in and look and be like, okay, what's going on here? Again, kind of skipping forward over the MMPI-2 stuff because it's a little outdated. I can talk about the 2RF a little bit here because it's really similar to the 3. So they shortened it quite a bit. It used to be 567 items and now it's down to under 350. And there's no overlapping items anymore. So they kind of pulled everything out and made it cleaner. So now they have what they call these higher order scales, and I'll kind of show you all as we go through. So this is the actual test booklet you would give to someone to take the MMPI. And so it's all the questions, and then they'd get a Scantron form where they answer kind of like the SAT or something like that. And so, for example, the first question is, my daily life is full of things that keep me interested. You know, someone saying no to that, they might be experiencing symptoms of depression. Then, you know, other items. I'm sure I'm being talked about, right? A little bit of paranoia there. I have lost hope. That's something we really want to take a close look at in terms of thinking about suicidality. I have a drug or alcohol problem. A sudden noise will often startle me, getting into like anxiety, PTSD type symptoms, right? I have some outstanding qualities. I mean, I hope people would endorse that, right? I frequently find myself worrying about something. So the new one, that MMPI 3, they cleaned up just a little more, so it's 335 items. So again, this is what the person would see, and then this is what the clinician gets. And I absolutely love how they redid this. It used to be, in order to interpret the MMPI, you had to buy a book. And there were different people who had different schools of thought about how it should be interpreted, down to, you know, if we go back and look at this chart, what cutoff you use to say someone had an elevated score. So if you notice, this chart says 70, there's a line at 70 for elevated scores. I was taught 65. And so it was like, did you buy the Graham or the Green or the Butcher book? And that's how you interpreted it. That's kind of problematic, right? Like, and it was, there's like rivalries. So I was trained, in addition to under Yossi, this the nicest guy, under Jack Graham, who was the Graham of the interpretation books. And one of the other guys came while I was on residency to teach us about the MMPI. And I sat near him at lunch afterwards and I said, oh, you know, I trained with Jack Graham. And he turned away from me and like did not talk to me the rest of the lunch. I was like, that was a thing that just happened. Okay. You know, even psychologists can be petty. So, but they changed with the 2RF and continued into the 3 is that when you buy the test materials, you get the official interpretation guide, which is really nice. And so for each scale, so let's say that demoralization scale I was just talking about, where they pulled out all those common items about just feeling awful, right? Because you have a mental illness. It'll tell you, okay, this person is scoring high they're experiencing significant demoralization, feeling overwhelmed, being extremely dissatisfied with their life. It says that they're at risk for suicidal ideation. They don't cope well with stress. And then there are things like diagnostic considerations. Evaluate for a depression-related disorder. It doesn't say diagnose them. It says, hey, this points you in that direction. And then it also gives you treatment consideration, right? We need to evaluate for suicidal ideation and self-harm. We need to think about emotional difficulties and will that help or hurt them engaging in treatment, things along those lines. And so each scale has something like that. And so they created, I'm gonna go back again here, these higher order scales that get at sort of the overall themes that come out of the MMPI. So emotional internalizing. So these are the disorders like depression, anxiety, eating disorders. You're focusing inward, right? It's sort of like you're in your own head. Thought dysfunction is like your psychosis, your schizophrenia, just like not really connected with the world, right? And then behavioral or externalizing dysfunctions are people who their pathology makes them lash out, right? So whether that is anger, whether that is acting out by, dangerously engaging in drug or alcohol use, things along those lines. So, for example, let's say you score high on this BXD scale. They indicate acting out behavior that's likely to result in marked dysfunction and to have gotten them into difficulties. You should evaluate for externalizing disorder. They're unlikely to be motivated for treatment. They are at a risk for treatment non-compliance. And they have inadequate self-control is something you should focus on. And then there are these restructured clinical scales. The demoralization is one of those. And then each of these sort of represents the core portion of what was originally on the MMPI 1. And so instead of having fancy old names like, psychesthesia, which was the anxiety scale, now we have just like dysfunctional negative emotions, because that's the core of what we're getting at. The depression scale, I think, is really interesting, is low positive emotions. And research in recent years has really showed that low positive emotions, and in particular the absence of experiencing those positive emotions, is like one of the biggest predictors of depression itself, but also just like having difficulty in, you need a lot more help to get out of the depression, if that makes sense. So, antisocial behavior, things along those lines. They also, for the two, have added some more scales to address things that hadn't been addressed previously. So for example, relevant to my area, they added an eating concern scale. The MMPI never touched on eating disordered behavior prior to that. And there are scales now that measure like cognitive or neurological complaints to try to get at, okay, is this actually psychological, or do they maybe have something physical going on that we need to send them for a referral, right, and try to find out. So there are lots and lots of scales that get at that fun stuff. And then the other cool thing within the personality realm is that there's also scales that measure the big 5 personality traits. So on top of getting sort of all this potentially diagnostic information, you get basic personality info. So very widespread usage and acceptance, just like thousands of studies about the MMPI. And the really nice thing is, like, from the 2 forward, the 2RF and the 3 are really made in such a way that you can still draw on the body of research from the 2. But there's obviously been a lot of research in recent years as well. And it really is the leading personality test. It is just really effective. All right, so the PAI is an MMPI, a like instrument, 344 items. Instead of just true, false, now we have not at all true, slightly true, mainly true, and very true. I don't really know what those mean, right? But it does give people more nuance. And I think for some people, they feel more comfortable answering when they have variety rather than just a true, false. Oh, I forgot to mention for the MMPI and also for this as well, there are adolescent versions that you can use with people 12 and up. So again, very similar in terms of the types of items. I'm so worried and nervous I can barely stand it. I rarely have trouble sleeping. My behavior is pretty wild at times. The thought of settling down has never appealed to me. I prefer to let others make decisions, things along those lines. So it also has validity scales. It sort of mimics the MMPI in several ways. It has a lower reading level of some of the other tests, although I'm trying to remember what Yossi said the 3 is. I think it's somewhere right around 4th or 5th grade reading level. So it's really not that out of the realm. And this was developed using the rational method, which basically means they just gave a bunch of items to professionals and they were like, which do you think measures what? Here is the same type of thing you get for the MMPI with the PAI. What I like about the PAI, instead of just having one cutoff, it gives you what's called the skyline. And the skyline represents norms for the specific population you tell it your client's in. So there are different norms for inpatient people versus outpatient people, right? Things along that line. There are different norms for people who are going specifically for substance use treatment, right? Things along those lines. And so that can be really helpful. The PAI is widely used in the VA. It's actually integrated into their software and just populates into their charts. So I used it quite a bit the year I was on my residency there. The MCMI is another similar one. I unfortunately don't have an example of that one. There's the NEO-PI, which just focuses on the big 5. And that being said, there are a whole bunch of versions of this now. Like there are versions of looking at the big 5 that only have like 10 items or 25 items. So you can do that like for research. These are the big 5. The easiest way to remember them is OCEAN, openness to experience, conscientiousness, extroversion, neuroticism, and agreeableness. Alrighty. The other one that's not mentioned here, but I want to mention is the 16PF, which was developed based on different theories of personality. That's essentially what I like about the 16PF is that it's like each side of each scale has a meaning, right? Some of these other ones, you only interpret them if the person scores high. With the 16PF, it's like if they score low, that means something too. So again, similar packet they would fill out. There are also shorter personality tests that are very specific to usually one type of disorder. One of the most widely used is the Beck Depression Inventory. It was created by Aaron Beck, and who just passed away last year. I think he was 100 when he died. It kept working well into his 90s. 21 items measuring the symptoms of depression. Alrighty, so now we're going to get into the projectives, and this is what Dr. Jensen mentioned in passing when she was talking about the Rorschach. So these are purposely ambiguous. The interpretation is based on Freudian theory, and the idea is that people will, if you give someone something ambiguous, there's no right or wrong answer. In order to interpret it, the person has to use some of their own information, knowledge, personality. So they project themselves onto this ambiguous stimulus. So the idea is that tells you a lot about the person. These are harder to fake because people don't really know how to respond to them. However, if you're not using a systematic scoring system, like Dr. Jensen and I were talking about the Exner system, that's a systematic scoring system. A lot of psychologists will just sort of interpret it themselves. Obviously, you don't have that standardization if you do that. And a lot of these don't have a lot of great research about their psychometrics. All right, the most popular, the most famous is the Rorschach. So this was created in 1921. It was based on a popular parlor game called Blotto, where you would, this is back when they had like fountain pens and ink balls, and you would drip some ink on a piece of paper, fold it in half, unfold it, and everyone would be like, "Ooh, here's what I see." It's kind of like kids laying on their backs looking at clouds, right? And finding animals in them. And so you show people the card. This is card 1 of the Rorschach. And you just say, "What might this be?" And then you hand them the card. As you can imagine, people are like, "What?" And so then you record everything that happens from that moment on. You record everything they say. You record if they like turn the card while they're trying to figure stuff out. And so you go through that for each of the 10 cards. And you need at least 14 responses to score it under Exner system. So if the first one, they only give you 1 answer, then you say, people often see more than one thing. What else might this be? But typically people are like, get really into it. So I'm not going to analyze you. It's a really complicated process actually to do it, but anyone want to take a guess or say what you see in this plot? What's that? A hat?
A bat.
Oh, a bat. Yes, a bat is a really common response on this one. Yeah. I see a wolf. Like it looks like a wolf head to me. Some people see like 2 elephants. Okay, so there are all kinds of different things, like these things in the middle. I don't know how clearly y'all can see it from where you are. Some people look like, say it looks like people with their hands up, like praise hands emoji. And then what I really liked about the Exner system is then you have this book, kind of very similar to the MMPI book, where there's a lot of great information for you. So let me get to block 1 here. So it tells you in these tables what are common responses and what are sort of weird responses. It tells you, how to refer to each area of it. People can actually use the negative space, the white space, and those have area numbers. And then it really helps you that way. I really appreciated that about the system because it can be pretty complicated. And this is the John Exner system. After you've gone through all 10, then you go back. And I'm not going to remember the exact phrasing, but you essentially say, like, can you tell me where on the splotch you saw, whatever the response was. And then they describe it to you more. And again, you take those things into account. This is actually my pet who is now deceased, Finley. Yes, this is a really good question, Jade. In general, people should only give these tests who are qualified. But for sure, you should never give the Rorschach if you don't have that extensive training Dr. Jensen and I talked about the other day, because you could just make some shiz up. That wouldn't be good, right? But yeah, I just thought this was funny. I had the Rorschach at home when I was in grad school because I was giving it at the hospital, but I needed to borrow it from my training clinic. So I just put it up and decided to see what my cat would do, and she just stared at it for a while. It's really interesting. She didn't normally care about like pictures. So here we go. Help me see as you see it. Some people see more than one thing. And so you look at things like, where did they do it? What are they talking about? How frequently are they bringing up various things? You look at things like texture. If they mention that, that means something. And so these we kind of think the Rorschach is black and white, but there are also ones that have red on them. And my favorite, yes, I have a favorite Rorschach blot. I have a dress with the Rorschach blot on it. I should have worn it today. Oh well, I'll wear it next week. And then like, this is my favorite Rorschach blot because it's got all kinds of cool, crazy colors, right? Quick side notes about the Rorschach. Yes, it is based on Freudian systems, so there are things that are meant to elicit like phallus, right? Or perhaps vulva. And so, you know, that kind of takes you aback if you're not used to it. But you might be like, Dr. Myers, why are you showing us all these? Shouldn't you be worried about test security? Well, I should. Wesleyan paid $75 to buy these for me when I got here. And then I felt real dumb because if you go to the Wikipedia page for Rorschach, all the plots are posted. Oh, well, it's more fun to hold it in my hand, to be honest. But yeah, that's a real problem. It's copyright wise, but they can't get them to take it down. So, all right, the TAT is another popular projective. These are pictures with no context, and you just have the person tell you a story about what they see. And then based on that, you score it. And so some of them have people, some of them just places, right? My favorite story I got told was one of my undergrad professors said that they showed this block to this picture to somebody and asked them to tell a story, and they were like, well, the water's really calm now, but a couple minutes ago it wasn't because there was someone who you just drowned there. And they were like, what? Right? So people put all kinds of things on it. It's much more loose. There's no manualized. I mean, here's the whole manual for the TAT. There's no standard scoring system. And also you don't use all the cards every time. There are different sets you might use for different ages, different genders. There's also children's versions as well. These are some example images, right? So like for this one, I've had people say, he's dead, he's sick, she cheated on him, he cheated on her, right? All kinds of things that you can see. So for the TAT, you end up just sort of looking for themes, essentially. Sentence completion is the one I've given the most often just because it's the easiest. You give someone a paper, front and back, and they fill it out, or you like work on something else. And it has the starts of sentences, and that's your ambiguous stimuli. So like the first one here is, I like, right? And then the person's just supposed to finish the sentence. But again, we've got some Freudian things, because it is a projective. A mother. Lots of ways you can go with that, right? And so here again, you just look for themes and score it that way. So here are some more examples. Right, behavioral assessments we often do with kiddos, although certainly you can do them in other scenarios. We might do them, you know, like observe it, school psychologists might do them sitting in the back of the classroom when a kid's in school. Or we might bring them into the clinic or the lab and, you know, have one of those one-way mirrors and observe them that way, or just observe them interacting with their parents. The way it's most traditionally used for adults is self-monitoring. So, I was just about to say back in my day, like I'm ancient, but when I was in grad school, this was all on paper and pencil. You would copy them worksheets, they'd carry them around for the week. Now, the vast majority of time, it's going to be on an app. And there are various therapy apps, and the person might even get push notifications throughout the day to remind them, you know, let's say we're working on insomnia. You know, when did you go to bed? When did you get up? How many times was your sleep disturbed in the night? Things along those lines. So here we go, technology. And that is the whole PowerPoint. The only other thing I wanted to show you all today is, I didn't have this the other day, but this is the structured clinical interview. So this is, you know, again, very standardized, very like, you follow these instructions, you do not deviate from it. Very different from the interview y'all are gonna do right now. And so I know not everybody's here. I think we'll have 2 pairs and a 3. And so you can kind of like take turns. And I've had people do these a couple different ways. Sometimes they'll do all the questions for one person and then all the questions for the other. And sometimes they alternate. Like, you answer the question, then I'll answer the question. Whatever works for you. And just get as far as you can in the next 25 minutes. Yeah, so look at it for a second. And so it's up to you, as you are the interviewee, if you want to answer them honestly as yourself, or if you want to make up a persona. You want to be someone with depression or, you know, something else going on. But it's totally fine if you're just like, well, brought me to the clinic today, so I'm stressed about school. That's fine. So there's a whole bunch of questions. You can either take notes on this page or like take them on your laptop, you know, whatever works for you. There is an assignment related to this where essentially you are going to just write up a mini version of an intake report and then write about what it was like. So I will make sure that's available on Blackboard while y'all are doing this. And then I'm here, so ask me any questions as you go through it. But basically, you're just asking the other person the questions, and some of you who have been in like assessment with me or even making the service class have seen like a version of this before. And then what I'll do for people who aren't here is I'll just post this and they can either pair up with people in class or do it with people outside of class. And I'm just saying that for the recording. So, and for Jade, who's on. So Jade, if you want, because for the rest of the class, they're just gonna be doing that, you can actually sign off. And I will post that so you're able to do it with like a friend or a family member if you want.
Okay, awesome. Thank you.
Alrighty.